our today's oncology school, and I will introduce you in Russian. After that, you can start your talking. Сегодняшняя наша школа онкологии посвящена трижды негативному раку молочной железы. Как вы знаете, на сегодняшний день существует около 250 разновидностей различных типов рака молочной железы, но самым неблагоприятным в настоящее время является трижды негативный рак молочной железы, так как практически никаких рецепторов на опухолевых клетках нету и нет возможности как-то таргетированно воздействовать на данный вид рака молочной железы. Поэтому сегодня мы попросили профессора Майкла Мартина провести лекцию по проблеме лечения, диагностики лечения трижды негативного рака молочной железы. Так мы можем начать свою презентацию. So, dear professor, you can start your presentation now.
Thank you. Can you see it?
Yes.
Hopefully you can see everything now. All right, so I'm going to talk about triple negative breast cancer. I'm predominantly going to talk about localized disease, or stage 1 through stage 3 today. I may talk a little bit about stage 4 depending on time, but there's been a lot of changes and a lot of recent publications talking about how to take care of localized triple negative breast cancer. So a lot of what we'll talk about is adjuvant and neoadjuvant therapy for triple negative breast cancer. So how do I... Okay, so triple negative breast cancer is, in the US, relatively uncommon. 1 out of 8 American women will get breast cancer, but the vast majority of those are actually going to be either ER, PR, or HER2 positive. In the US, it's only about 10 to 15% of breast cancers will actually be triple negative breast cancers. And it is more common amongst young or Black women in the US, arguing that there is some kind of genetic predilection amongst people of African descent for triple negative breast cancer. There are also typically higher grade breast cancers, which changes both the relapse kinetics and the danger of the cancers. The one thing to point out, though, is that not all triple negative breast cancers are bad. When you look at gene expression profiling and you're looking at calling people luminal A, B, basal, HER2 positive, or what have you. Those are research terms, as you know. Those are not, should actually not be used clinically. When I was there in Uzbekistan, it seemed like people used those terms clinically a lot, but those are research terms based on fresh tissue put through RNA profiling. You can't really define luminal A and B based on ERPR and Ki67. It doesn't match up well enough. That's why in the US we use Oncotype DX a lot, or MammaPrint or something else. We use Oncotype more than anything else, but it's because it's more complicated than just those 3 variables. They give some degree of approximation, but they're not perfect at all. Anyway, nevertheless, there is a group of triple negative breast cancers that when you do gene expression profiling, which again is that SNP RNA profiling of them, that actually come out as luminal A, even though they, in this, again, in a research setting, even though they are triple negative. So how do you explain that? Those tumors are almost uniformly AR or androgen receptor positive. So there is a group of triple negative breast cancers that are AR positive, and they will actually behave as a luminal A cancer rather than as a true triple negative. So while clinically, generally triple negative breast cancers are high grade, lethal, rapidly spreading cancers, not all of them are. This is looking at a paper that I published after spending time in Nigeria, looking at the different types of breast cancer subtypes in Nigerian women, one thing to point out, and really the reason to show this, our study here, is that in Nigeria, almost half of the women were triple negative, which I think is a very important point to make, because again, going off the comment that there is different genetic predilections to different types of breast cancer. Again, US, it's 10 to 15% triple negative. In Nigeria, it's nearly 50%, showing the large difference that genetics can make. So we're going to talk about localized disease again, with a really focus on adjuvant and neoadjuvant therapy. And again, I will get to advanced disease with a couple slides maybe at the end. One thing to know about triple negative breast cancers is this is looking at your relapse kinetics. They behave very different than ER or PR positive breast cancers. ER/PR positive breast cancers, demonstrated in the red line here, have a constant low rate of relapse that extends over 20 to 30 years. So a woman with the ER positive breast cancer can easily relapse 20 or 30 years later. Her risk each year of having a relapse is very low, but it's consistent and it goes on again for decades. In contrast, triple negative breast cancers nearly always, if they're going to relapse, nearly always relapse within 3 to 5 years. That's when you could actually say that someone is potentially cured from a breast cancer, is when a triple negative breast cancer patient makes it out about 5 years. Again, that's dramatically different than a woman that's ER or PR positive. And the one thing about that then is it's also talking about probably the sensitivity of sensitivity to chemotherapy with triple negative breast cancers. As we all know, the tumors that are more proliferative respond better to chemotherapy. And really, as you see, driven by these relapse kinetic curves, triple negatives are much more proliferative, so they're going to have more benefit from chemo. This is again looking at a similar graph, talking about risk of relapse over time and recurrence. Again, you can see that triple negative breast cancers peak early from their time from diagnosis for their hazard ratio for recurrence and killing somebody. But then it goes away or goes down, versus ER positive. The longer a woman lives post her diagnosis, she continues to accrue greater risk of relapse over time. When we're looking at NCCN guidelines for triple negative breast cancer, when you have a patient who has already had her lumpectomy or mastectomy, again, I'm going to talk about everything from a medical oncology point of view. I'm not going to go through surgery or radiation because that's not what I do. Looking at it, any tumor at about 6 millimeters or higher, we consider giving adjuvant chemotherapy. At 1 centimeter, we absolutely start giving chemotherapy, and lymph node positive, we absolutely give chemotherapy. So in an adjuvant setting, if the tumor is 6 millimeters or more, we're giving chemotherapy to attempt to prevent those relapses. So this is women who are post lumpectomy, and we're talking again adjuvant therapy. So what kind of adjuvant therapy do we do? Looking at this is a paper that was actually extremely influential, that was comparing 4 cycles of adriamycin and Cytoxan to 4 cycles of Taxotere and Cytoxan, and showing a superiority for women with who receive TC versus AC. This is going out over many years. So this is looking at disease-free survival. Again, the TC curve is yellow, AC curve is blue. You can see that TC is superior. It is superior regardless of age, which is what this is. These curves are breaking out. Though older women do worse in general, they still benefit from the TC over AC. As you can see, the gray bar is the TC for older women, and the reddish bar or line is over 65 with AC. And again, blue is TC, yellow is AC. So since you can't tell a woman to become younger, but you can change her chemotherapy, you can see that TC is superior regardless of age for both overall survival and disease-free survival. So this really changed the metrics for us. So for a node negative, triple negative breast cancer under 3 centimeters, so anything between 6 millimeters and 3 centimeters, we will consider giving 4 cycles of TC adjuvantly based on this study. Looking also at this study, when you start looking at subgroups, while every subgroup benefited from TC versus AC, the group that probably benefited the most was the triple negative breast cancers with a hazard ratio of 0.7, even more so than the ER or PR positive patients. The next question came up is 4 cycles of adjuvant TC enough? So this is another large alliance study. All of these are very large randomized phase 3 clinical trials done in the US and Europe with thousands of women that I'm quoting. So this was looking at, is AC times 6 or is AC times 4 better for women as adjuvant therapy? This study also looked to see if you could get away with just giving single agent Taxol instead of giving AC. The answer to that question was no, you cannot. The blue and the gray lines, which are inferior on this relapse-free survival curve, are the single agent paclitaxel. So don't do that. But as you can see from the maroon and yellow lines, there is no difference in survival between 4 and 6 cycles of AC. Therefore, you extrapolate then, or it's often extrapolated back then, that 4 cycles is adequate. I would rarely use 6. The only way I can think I would use it is in a neoadjuvant situation. And I can give that example when we get to neoadjuvant therapy where I did that. But otherwise, in an adjuvant situation, 4 of TC is adequate for a tumor, triple negative tumor between 6 millimeters, 3 centimeters that is node negative. Okay. So what do we do for anything bigger than that, or that's node positive? So this is a study. We are reaching way back now, but this is looking at does the addition of Taxol to AC help? This again was a large randomized phase 3 trial where all women got AC every 3 weeks for 4 cycles, and that was followed by Taxol for 4 cycles versus nothing, and that was a randomization. The one thing to keep in mind, again, this is an adjuvant study, is that when we use ACT, though I don't have the slides in, we give them in a dose-dense fashion now. We do not give them every 3 weeks. We give them every 2 weeks. And the first author for that paper, if you want to look it up, is Citron, C-I-T-R-O-N. And it's also from the Journal of Clinical Oncology, published right around the mid-90s. So while this slide says every 3 weeks, we actually do it every 2 weeks. There is a real but small 2 to 3% survival advantage for doing it dose dense. Okay, but anyway, so going to this study again. So now in your mind, if you're making little buckets of what I'm talking about, this bucket is 3 centimeters or more, or lymph node positive that we're going to be addressing for triple negative breast cancer. So looking at this study, 1 dose escalation of adriamycin did not help. So just using a 60 of adriamycin is fine. There was a huge debate about adriamycin dose escalation in the 90s related to when people were doing autologous stem cell transplants for breast cancer. Do you guys know the story of autologous stem cell transplants for breast cancer? Alice here. Hello? Is anyone there? Am I talking to myself? Alashir.
I'm sorry. Pardon, Dr. Martin?
Yeah.
I'm here.
I was, okay. I was just wondering, is this just you and me, by the way?
Could you rephrase your question again?
So is it just you and me on this call?
No.
Okay, that's what it looked like on this. Anyway, do you know the story of
I think we also uploaded this video. So today is only one participant now, but I think it will be very useful for our students because I will upload it to.
Okay, so do you know the story for bone marrow transplant for breast cancer?
No.
Okay, so that's really where this slide was going with as far as dose escalation of doxorubicin. Right around the mid-90s, there was a paper that came out of South Africa, out of Cape Town, that showed that if you dose escalated women with adriamycin and Cytoxan, just simple AC, to literally homicidal levels of the drug, and gave them stem cell support, you could quote unquote cure women with stage 4 breast cancer. And that was obviously a revolutionary paper. So it really had the idea that dose escalation for chemotherapy for breast cancer could cure women. And that's kind of where this paper was going, where they're dose escalating their adriamycin. They're seeing no benefit. But I guess the long, sad story is all of that was actually falsified data out of South Africa. They actually never did the study. They just, they never did the study. They made up the data, and thousands of women ended up in the US getting bone marrow transplants for breast cancer for no reason, based on fake data. The people who did the study in South Africa eventually, after it was unable to reproduce their findings in other studies in Europe, admitted that they had completely made it up, and that there was no data for it, which is a horrible little chapter in breast cancer history. Anyway, so this is kind of starting to test that idea of dose escalation in breast cancer, and showing that really dose escalation in breast cancer does not help with adriamycin. So now this is looking at Taxol, the addition of Taxol to AC. And you can see that with Taxol, the addition of Taxol improves both overall survival and disease-free survival by about 6%. So what people did it specifically help when you start looking at the hazard ratios for that, the people who were really helped and where the benefit really was driven by the addition of Taxol was not in the ER positive patients. As you can see from the confidence interval, it crosses 1, arguing that this is not even statistically significant. It really was driven by the receptor negative patients. They're the only group that had a significant confidence interval. So the triple negative patients, this paper is actually too old to have HER2 in it, but for people who were ERPR negative, they're the ones who drove the benefit. And that's shown both in this line and in the line where they said received no tamoxifen, because again, those would be, you're using that as a surrogate for people who are receptor negative. And again, that's where all of your benefit is coming from. And that's why it's relevant to this discussion. Looking out at the node positive people, the addition of the Taxol made a significant benefit to ER negative, but not ER positive patients, as you can see in these survival curves. And again, all these studies that we're referencing are talking about thousands of women. This has got 1,300 women in it. And you can see that there's a dramatic benefit for the Taxol in women who are node positive, who are triple negative, versus women who are ER positive. You're not really seeing the benefit from the addition of Taxol. going through then looking at a combination of multiple clinical trials, again, showing this is now looking at TC times 6 versus AC plus T as, again, adjuvant therapy. Again, showing that the ACT benefits the hormone negative people, or in the people with the most lymph nodes the most. Really, the hazard ratios are driven by the triple negatives for the combination of AC plus T. So how to give your T. So really, again, if we're creating buckets in our head, 6 millimeters to 3 centimeters, no lymph nodes, triple negative is TC times 4. Over 3 centimeters or node positive, as I've just shown you, is AC plus T. You can also see that in ER positive patients, you're not getting nearly the benefit, and most of the benefit shown in these studies was driven by the subgroups of the triple negative patients. Now, again, because of the Citron paper that I referenced, we give the AC in a dose-dense fashion. So we give the AC every 2 weeks with growth factor support. But then the question came up, how best to use T? And also, could you use docetaxel instead of paclitaxel? So this was a 5,000 woman randomized trial, which is a massive clinical trial, asking the question, how best to use your taxane? If we've already shown that adding a taxane to women who have a larger tumor or are node positive, particularly triple negative women, benefit from the addition of a taxane, should you give it as weekly docetaxel every 3 weeks, weekly paclitaxel, or paclitaxel every 3 weeks? Those were the 4 arms randomized in this study. Looking at it, the weekly paclitaxel was superior. So that's 12 weekly doses of paclitaxel. That's the yellow line that you can see at the top, showing that the 5-year overall survival was superior doing it that way. And you had the best overall survival approaching 90% at 5 years. So we typically will actually use weekly paclitaxel. And it was actually the only thing that was superior to every 3-week paclitaxel. And weekly paclitaxel is very easy to give. If you're now looking at it, again, here, it's just breaking out in other groups, just showing as we go out to 10 years, because remember, this data stopped at around 5 years. If you keep following it out all the way to 10 years, you can see that the weekly paclitaxel is indeed superior to docetaxel given in any fashion and every 3-week paclitaxel, both for disease-free survival and for overall survival. So this is probably the preferred way to give paclitaxel. It's very easy to give as far as it's very, very tolerable. And it is superior to any other way of giving a taxane. So it's 12 doses of weekly paclitaxel. Interestingly, when you start breaking it down into the HER2 negative subgroups in this 5,000 person trial, the question of weekly versus every 3-week paclitaxel, the difference was driven almost exclusively by triple negative breast cancers, which is what you're seeing in this slide. So overall survival for triple negative breast cancer and disease-free survival for triple negative breast cancer was really driven very strongly. It was really what drove this data. The hazard ratios in ER positive breast cancer actually did not show a benefit at 12 years for weekly versus every 3-week paclitaxel. So really, again, a more proliferative disease is more chemosensitive, which is why you're seeing that the addition of multiple chemotherapies and more chemotherapy helps the triple negative population. So the current standard, as I just reviewed it, for adjuvant therapy for triple negative breast cancer in the US for triple negative disease is, again, 6 millimeters to 3 centimeters TC node negative TC times 4. Keeping in mind, again, there is that small subgroup of patients who will actually behave much better, almost like a luminal A, and those will be the androgen receptor positive triple negatives. Then anything over 3 centimeters or node positive for triple negative breast cancer, the standard would be AC times 4, given every 2 weeks with growth factor support, followed by 12 weeks of weekly paclitaxel, as I just showed. This is really where you're getting the survival benefit and the additional benefits of therapy, additional therapy for these women. So that's 12 weekly doses, and that's all in an adjuvant fashion. So post-mastectomy or post lumpectomy. So going on from adjuvant therapy to neoadjuvant therapy, and the slides are actually going to be mixed between the two going forward. Neoadjuvant therapy is where we move chemotherapy before surgery. The reasons to do this is, one, you can shrink a tumor and try to save the woman's breast. There is no survival difference in neoadjuvant versus adjuvant therapy. So it doesn't matter if you give it before or after. That's been shown in those 2 very large randomized studies. It's equivalent either way. But what it does give you the opportunity within triple negative breast cancer is it gives you kind of a biological test, right? So it tells you whether or not your chemo is working. And if your chemo didn't work, then is there something else you can do about it, right? So that's probably what has become by far the main advantage or the main rationale behind using neoadjuvant therapy. And a lot of breast cancer therapy has now moved to the neoadjuvant setting. And really, so we're moving our TC or our AC plus T before surgery. And again, the reason for that is, if we look at this curve right here, women who achieve a pathologic complete response or PCR do dramatically better than women who do not achieve it. So if you give all your chemotherapy up front and then go to surgery, you can tell, did the chemotherapy work or not? And then now we will tailor adjuvant therapy to the PCR rate. So if a woman achieves PCR negativity with her neoadjuvant chemotherapy, then she has her surgery and her radiation. She needs no more therapy. But if you give neoadjuvant therapy to a woman with triple negative breast cancer and she does not achieve a PCR, that's when you start giving more chemotherapy post-surgery, because you're trying to affect this event-free survival curve for the women who do not achieve a PCR. And indeed you can, and we'll go through those studies. Of note, PCRs are not meaningful in ER positive patients, but they actually are very meaningful as well, also in HER2 positive. And we will actually give adaptive therapy as well for HER2 positive disease. So people who you can give this to are people who are candidates for preoperative therapy are listed right here. Obviously, if you cannot remove it, they need neoadjuvant chemotherapy. The other ones, though, to consider are in patients who have operable breast cancer, but who are triple negative or HER2 positive, because we just talked about how you can do adaptive therapy, who are either lymph node positive or have a palpable lesion. So, because again, what you're trying to do is you're trying to define a group of women who you can shrink their cancer or try to achieve that PCR. Okay, so looking at that, the first attempt to do this is looking at women with T2 or node positive breast cancer, triple negative breast cancer, adding carboplatin to the AC plus T. By adding carboplatin with the CLGB study, you were able to increase your PCR rate, but not statistically change event-free survival. So this is one of the first studies really looking at adding something in. So there was that in another study, they also showed that adding in carboplatin would improve PCR by about 16%, which again was good. That study actually included bevacizumab, which is not used in the US neoadjuvantly. So if you see that anywhere in these slides, ignore it. It does not work. This is graphically breaking down those two studies, which I think is much easier to see. This is looking at using weekly carboplatin. So basically you give AC dose dense times 4, followed by 12 weeks of weekly carbotax in triple negative breast cancer patients. You can see that there was a significant improvement in PCR rate, which is really what you're going for. And there was actually a statistically significant difference in 3-year disease-free survival. And this is a meaningful endpoint in triple negative breast cancer because, as you recall, most relapses are happening in 3 to 5 years. In the CALGB study, they also showed a significant improvement in PCR rate, but they showed no difference in event-free survival. So really what I think is driving the difference between these two studies is that in the GeparNUEVO study, the carbo was given weekly, which is very tolerable, and you're actually able to maintain dose intensity quite easily. You occasionally have to drop your carbo, because again, remember the Taxol is the more important of the two drugs, but you can usually get women through it. As opposed to they gave the carbo every 3 weeks in the CLGB study, which is extremely hard to do with Taxol, especially after you just hammered someone with AC times 4. So I believe their dose intensity was significantly worse, and I bet you that's what drove their lack of seeing a significant benefit. So there is some benefit to the neoadjuvant carboplatin. Not everyone gets it. You would give it clearly for an inflammatory breast cancer because those are the women who have the most risk of distant disease. A woman who has a locally inoperable breast cancer or a large amount of disease burden when you meet her. And people who can take it by adding in that weekly carbo, which is the way that we will typically do it. We don't do the every 3 week. You are adding significant toxicity. Interestingly, the main toxicity you see is diarrhea with it, diarrhea and cytopenias. So adding it in, you don't add it into the frail 83-year-old. You're adding it into the young, healthy person who you're trying to get that extra 15% PCR rate, because as I already showed on the slides before, PCR makes a huge difference in survival. So can we get even more fancy with neoadjuvant therapy? So this is looking at atezolizumab and pembrolizumab in metastatic stage 4 breast cancer, triple negative breast cancer. And these are what are called spider plots. I'm not sure if you've seen these very much, but basically every bar represents an individual person, and the going on the y-axis is a change in tumor size, going on the x-axis is the number of days on study. These drugs are minimally active in advanced breast cancer, especially if you contrast it to what we've seen with Hodgkin's disease or what we've seen with lung cancer. There's not nearly the benefit that you see, and there's only a very small percentage of women actually benefit from these drugs in the triple negative setting, though some women do. So being eternal optimists as oncologists, we said, hey, at least some women responded in the triple negative group. Why don't we go ahead and throw that into neoadjuvant therapy? So what this study did, which that sounds a little bit brash to me, but that's actually what they did. And again, they randomized people to either 12 weeks of weekly paclitaxel with or without pembrolizumab, followed by your AC times 4. And it showed a significant improvement in PCR rate. So as opposed to adding carboplatin, which increased your PCR rate by about 15%, when you added it to triple negative breast cancer patients, pembrolizumab rather, you got a 60% pathologic complete response rate, which is very, very good. And then looking at event-free survival, there was also a benefit from achieving a PCR with a pembro, going out to 3 years. Of course, there were autoimmune side effects. You saw a lot more adrenal insufficiency, actually, than you do when you use the drugs in other situations. One thing that's always interesting about learning and using the checkpoint inhibitors like pembrolizumab, nivolumab, and ipilimumab is that the profile is different, or the toxicity profile is different for the toxicity profile is very different depending on the disease you use it in. In breast cancer, you see a lot of adrenal insufficiency. Interestingly, when you use it in lung cancer or kidney cancer, you see a ton of thyroid disorders. When you use it in melanoma, you see a whole bunch of vitiligo. When you use it against thymomas or thymic carcinomas, you actually see myocarditis. So interestingly, when you use the checkpoint inhibitors in breast cancer, you see a lot of adrenal insufficiency. So continuing to play this out, can you actually use these drugs? This is now looking at durvalumab, again, with neoadjuvant therapy in early triple-negative breast cancer. So again, the improvement in PCR status is around a 15% benefit, and actually happens regardless of PD-L1 status. TILs correlate with PD-L1 expression, predict for PCR, and they're prognostic. But again, PD-L1 status does not matter for using these drugs, which does not make a ton of sense. So this was looking at follow-up for 3.5 years. Again, this is a phase 2 study comparing adding durvalumab to neoadjuvant chemotherapy with triple-negative breast cancer. It did improve regardless of PD-L1 expression, the PCR rate by about 10%. And this is the study design. We looked at women who had lesions over 2 centimeters or were node positive. And you added durvalumab to nab-paclitaxel, followed by EC, which is the same as AAC. Okay, and again, you're giving your taxane over 12 weeks. You're giving your anthracycline in a dose-dense fashion. And I've already shown you the rationale for why it's done that way. But this is now adding durvalumab, which is a kissing cousin to pembrolizumab and atezolizumab. So looking at it, these were younger women because it's a triple-negative breast cancer. And then looking at the TIL expression. And going through, almost everyone got to surgery. And the 3-year disease-free survival was significantly improved with a hazard ratio of 0.48. So showing a 8% benefit for the addition of neoadjuvant durvalumab for survival, which I think is actually quite impressive. And it improved the PCR rate as well. And this was, again, regardless of PD-L1 status. So looking that also decreased, so sorry, this was invasive disease-free survival. So that's even another breast cancer or distant disease. It also improved distant disease-free survival. Again, the hazard ratio is 0.31, which is extremely good, as you know. And it also is trending towards, or actually showed a difference also in 3-year overall survival, showing that the addition of the checkpoint inhibitor to neoadjuvant therapy makes a big difference. And as you can see, this data is actually already more robust than the carboplatin data. So when you consider it, so the long-term benefit in this phase 2 study from the addition of a checkpoint inhibitor improved every metric in triple-negative breast cancer over 2 centimeters or node positive, improving invasive disease-free survival, distant disease-free survival, and overall survival. That is obviously very impressive. This is now Keynote 522. This is probably the most important of these studies because this has actually led to FDA approval. The publication you can see is down at the bottom right from the New England Journal of Medicine, but this is the study that is now, this is actually what is standard in the US. So I was spend a little bit more time on this study. So this is now taking women who have triple negative breast cancer over 2 centimeters or node positive, randomizing almost 1,200 women for neoadjuvant therapy. Okay, and it's giving that standard backbone that we had talked about with the carbotax, given in a weekly fashion, followed by AC or EC given in a dose-dense fashion, and randomize women to have either the addition of pembrolizumab or nothing to this. And so this is women with triple negative breast cancer in a neoadjuvant situation. So there was a difference in achieving a pathologic complete response by 14%. And this was seen both for PD-L1 positive and PD-L1 negative patients. I wouldn't make a bunch out of saying that the PD-L1 negative had a larger change in the path CR rate, but just seeing that there is a change in the path CR rate, regardless of PD-L1 expression, is encouraging, arguing that you can offer this to women regardless of PD-L1 testing. Looking at the forest plot, almost every group benefited from the addition of pembrolizumab. As you can see, this is the line of equivalence going down through the middle. Everything to the right has pembrolizumab, the addition of pembrolizumab showing a benefit for achieving a PCR rate, except for in people who had a poor or worse performance status. That's because when you do add in the pembrolizumab, you are making it a more taxing regimen. Looking at PD-L1 status, regardless if you're PD-L1 positive or negative, you again did get that benefit in PCR. If you look at event-free survival then, going out, there was also a difference in event-free survival from the addition of pembrolizumab neoadjuvantly to these women. And then when you go out, again, this is taking it even further out, the curves continue to separate, showing that the addition of pembrolizumab to neoadjuvant therapy for triple negative breast cancer, including women who got AC plus TC, and that's Taxol carbo, there was still a benefit. So this is now giving 5 drugs in a neoadjuvant setting, showing actually remarkably good outcomes for these women with locally advanced triple negative disease, right? Because remember, these are node positive women. So out at 2 years in the group that received pembrolizumab plus the 4 chemotherapy agents, you're getting survivals of 90%. This is another study looking at similar things. I'm not going to go through this in detail as much, or I'll go through it quicker because it's saying, you can see it's the same study design. It's just another checkpoint inhibitor. And really what we're seeing is that with atezolizumab, durvalumab, and pembrolizumab, you're all getting incredibly similar results given in the neoadjuvant setting. It's exact same format, same kind of thing. Half the women are PD-L1 negative. And again, you are seeing a benefit from the atezolizumab in almost the exact same range. And it's extremely reproducible, as you've seen across all 3 agents. You're getting an improvement in your pathologic CR rate by 15 to 18%. It doesn't matter PD-L1 positive or negative. Again, these curves and these graphs, well, it looks like I'm being redundant and showing the same things. I'm actually showing different studies that all looked at the same notion of giving the neoadjuvant checkpoint inhibitors and showing the benefit for that. And nearly identical benefit percentages regardless of the agents, which gives you a lot more belief in the validity of it, because even though they're relatively small numbers of patients, you're seeing that everyone is benefiting regardless of PD-L1 status. And again, you're seeing the exact same thing regardless of which agent was used. Again, beating a dead horse, keep trying it different ways. And these are studies that are going on now, is then looking to add for people who did not get pembrolizumab up front. So people who had just AC plus T or with or without carbo, if you had residual tumor, giving them adjuvant therapy. So what is the optimal thing for neoadjuvant for early triple negative breast cancer? It is dose-dense anthracycline, weekly taxane with weekly carbo. We're going to get to the capecitabine thing in a second. But things that really come up is now adding the impact of neoadjuvant pembrolizumab with women with advanced disease. And again, that is approved in the US regardless of PD-L1 status for adding pembrolizumab for a total of 5 drugs up front. So what happens if you give 5 drugs up front and you still don't get a PCR? Well, this is the CREATE-X study that I think everyone's familiar with. So this was looking at women who did not achieve a path CR from neoadjuvant therapy. Again, this is another way of showing the benefit of being able to give neoadjuvant therapy is that you can get the biological test to see if indeed your therapy worked or not. While there's no difference in the drug's ability to cure, because remember, it doesn't matter if you get them before or after if you don't do anything different, but showing that if you give everything up front, you don't get the path CR. With the CREATE-X study, they randomized people to 6 to 8 rounds of capecitabine who did not achieve a path CR. As you can see, there's a significant improvement in disease-free and overall survival in the triple negative breast cancer population. And this was really what was driving the difference in this study. Showing that there was a significant improvement of, again, 14% to nearly 10% in overall survival and in disease-free survival, respectively, showing large benefits from the addition of 6 to 8 adjuvant rounds of capecitabine after you've given all of your neoadjuvant therapy. A question has come up saying, well, these women have triple negative disease, and they may be more sensitive to platinums. So this was a paper that was reported this year at the American Society of Clinical Oncology meeting, where you took women with the same idea who had received AC plus T up front and then had residual disease at the time of surgery and randomized them to 4 cycles of cisplatin or carboplatin versus the capecitabine. And you can see there was no benefit for the platinum over capecitabine in this triple negative population. And the platinum was much more toxic. So that really leaves the 6 to 8 of cape as still the adjuvant therapy for someone who failed to achieve a path CR with neoadjuvant therapy with triple negative breast cancer. So going on to another look at a way to change adjuvant therapy. This is the Olympia study, which was also just presented this year in June of this year. This was looking at adjuvant olaparib versus placebo in women who had HER2 negative BRCA mutated breast cancer. So you guys are familiar with PARP inhibitors. And again, BRCA1 is typically triple negative breast cancers. BRCA2 is typically ER positive breast cancers. And olaparib is a drug that specifically works to increase the synthetic lethality by handicapping the one remaining allele of BRCA in someone who has a germline mutation in BRCA to kill the cancer. So what this study did is it looked at triple negative women who had not achieved a path CR, as you can see right here. If they had received neoadjuvant therapy, or if they'd received adjuvant therapy, they needed to have a T2 tumor or a lymph node positivity. Extremely similar design to the Pembro study. And then you randomize women to a year of olaparib or not. Looking at it, the majority of women had BRCA1 mutations. They were young as you would expect them to. About half received adjuvant, half received neoadjuvant, but this is an 1,800 woman study. So it's a very, very large study, and 80% of them were triple negative. You can see there's a difference in invasive disease-free survival. going out to 3 years for the adjuvant olaparib. And then this is showing again that it benefited essentially every subgroup with a very strong benefit, regardless if women with triple negative breast cancer received adjuvant or neoadjuvant therapy, showing a hazard ratio of 0.54 and 0.55. So a very large benefit for women. As far as invasive disease-free survival, again, you're seeing about a 7% benefit. And overall survival, a trend towards benefit, which they are saying is already statistically significant. Again, small benefit, but a benefit. So it was very well tolerated. Olaparib was very well tolerated in this situation with minimal dose reductions. And importantly, something that we always worry about with olaparib is the incidence of MDS or AML, and there was no difference in that, though this is only 3 years of follow-up. And as we know, MDS and AML can develop 8 to 10 years after giving chemotherapy for breast cancer. So again, they concluded that it worked. So this is another thing to consider. And those are all of my slides on adjuvant and neoadjuvant therapy. So to summarize really what I would say, would be, okay, so I guess really what I would say, the standard in the US at this time would be that any woman with a, who was looking for breast conservation, who had a palpable breast cancer over a couple of centimeters, you're going to consider neoadjuvant therapy. If you're giving adjuvant therapy, again, it's under 3 centimeters, between 6 millimeters and 3 centimeters. Node negative is TC times 4. If you're giving adjuvant therapy, it is AC plus weekly T with weekly carbo for women who are node positive or over 2 to 3 centimeters. If you're giving neoadjuvant therapy, it is 5 drugs. At this point in time for node positive, it is weekly paclitaxel carboplatin with pembrolizumab, regardless of PD-L1, then followed by dose dense AC plus, dose dense AC, then surgery. If there's residual disease, they then get capecitabine. If there is a BRCA mutation, they would then follow the capecitabine with a year worth of olaparib. So you've gone up now to potentially giving a young woman who had a BRCA mutation with triple negative breast cancer in an adjuvant and neoadjuvant situation, up to 7 drugs attempting to cure her. Because really, with the goal of adjuvant and neoadjuvant therapy is to improve survival, because as we know, surgery by itself will still have unacceptably high relapse rates. So really, this is the systemic approach to localized disease, showing dramatic benefits and changes over time. And that is my talk on localized triple negative breast cancer. Thank you.
Yeah. Thank you, dear professor. I have several questions for you. During the treatment of localized breast cancer, triple negative breast cancer, you use almost all the arsenal of the drugs and regimen. So what will you do when it will be the progression after some time? I mean,
so what you're doing is you're taking your shot now, because this is your chance to cure them. If they progress, they are going to die no matter what you do.
I see.
Right.
And
so if a woman then progresses, then you still have tons of different chemos you can use. So they haven't seen gemcitabine, they haven't seen vinorelbine, they haven't seen ixabepilone, just off with they haven't seen eribulin. So there's 4 lines of chemotherapy without even thinking. Also, we have sacituzumab that we use in triple negative as well. So there's 5 drugs in your arsenal. You have drugs used in someone who's, but you can't cure a relapse. So the point of adjuvant and neoadjuvant therapy is to sandwiching it with surgeries to actually cure the women.
and it will be some period when you tell your patient that you cannot, nothing to do, and what will you do with that patient who are still alive, but you cannot do nothing. It's,
Hospice.
I think from the moral point, it's very difficult to tell
No, it's
patients
not.
that.
No, you have to do it. Because the thing is, you only can treat someone as long as you have data, right? So there's no data to treat women beyond 3 or 4 lines of therapy for metastatic disease. So at a point, you're giving false hope in not being honest, right? So there is a point where there is nothing you can do, and people need to know that. And so as soon as we meet someone with stage 4 disease, I will tell them on my first meeting with them that they will die from this cancer, and that at some point in time, we will run out of options and we will have to stop.
Nice. And they usually refer to the palliative care, or they use some symptomatic therapy. Am I right? Okay.
Yeah. Okay. So palliative care is a big issue, but we will not treat beyond data, right? So there's no data to give a woman 8 lines of chemotherapy.
I see. But very interesting.
It's actually a waste of money. It's a waste of money because it's not doing anything, and it's a waste of money. And also not being.
You're true.
And it's not being honest with the woman, right? She has to know that she's dying. But the reason that you're unloading with the arsenal and adjuvant and neoadjuvant settings is so you never get to the point where you have to have that conversation.
It's very interesting. But still there is no good drugs for the triple negative breast cancer. I mean, the data is good, but
I just showed you
90%
survivals. This is,
pardon?
I mean, I just showed you 90% survivals with these women with localized disease.
But I mean, if you compare with another types of breast cancer.
No, I mean, even HER2 positive, 90% is what you'll get. So no, by unloading with the arsenal, I mean, a 90% 5-year survival for localized disease, even node positive, is extremely good.
Thank you. Thank you so much for your today's lecture. I hope to see you again. Today, I applied all your documents to our institute, and I think they will provide me the certificate to you on Monday. I will send the certificate for you about your employment as a visiting professor.
Thank you so much.
I will try to do something beautiful, some beautiful diploma for you about this. only for your CV. I think it's very good. It's very good for you. Okay, see you next time.
See you next time.
Bye-bye.
Bye.